Good evening. My name is Dr Navalkissoor. I'm one of the consultants in nuclear medicine at the Royal Free Hospital. So I'm one of two consultants. You may have, some of you are familiar faces. You may have met my other colleague, Dr Quigley. So two of us to do the radionuclide therapies at the Royal Free Hospital. And today I'm going to be speaking about the radionuclide therapies that are available for patients with neuroendocrine tumors. So this is the outline of the talk that I'm going to be doing. I'm going to talk about different radioisotopes that are used, patient selection for radionuclide therapies, the timing of therapies, some outcome and toxicity data for these therapies, and lastly I'll talk about some practicalities in Prrt. Okay, so firstly, these are the two different targeted treatments that are available for radionuclide therapy in neuroendocrine tumor patients. I-131 MIBG and Prrt, which I'll explain what that is in a little bit. So I'm only going to have one slide on I-131 MIBG, as it is not used that commonly anymore in neuroendocrine tumors. It's taken up by a catecholamine mechanism of action, so similar to the catecholamine molecule. Neuroendocrine tumors overexpress these catecholamines, and they're taken up by amine uptake process. And so it can be used, and it is used in patients with pheochromocytomas and paragangliomas. In the past, it was used in patients with neuroendocrine tumors, as there's uptake in approximately 70% of neuroendocrine tumors do have uptake by this mechanism. But nowadays, somatostatin receptor scintigraphy has become more popular and more effective than MIBG. So not routinely used in patients with neuroendocrine tumor. Only if you don't have sufficient uptake on the somatostatin receptor scan can you consider this treatment. So that's all I'm going to be talking about this, because it's not routinely used anymore all around the world. It can be used in pheochromocytomas and paragangliomas, but not routinely in neuroendocrine tumors. And this is the focus of my talk. So Prrt. So what does that stand for? Peptide receptor radionuclide therapy. If you assume this is a neuroendocrine tumor cell, you can see that the neuroendocrine tumor cell overexpress something called somatostatin receptors, which is sort of like a hook on the surface of their cells. So using that, we can use a radiolabeled somatostatin analog. So this is the radiolabeled somatostatin analog that can bind to the somatostatin receptors, becomes high expression of somatostatin receptors. This radiolabeled analog can bind to this receptor. It becomes internalized by a receptor-mediated endocytosis process. And then the tumor damage is related to the radioactivity on this particle. So this particle is a somatostatin analog labeled with radioactivity, and the radioactivity causes damage to the tumor cell, and that gives you the effectiveness of this treatment.
Normal cells don't have those receptors?
There are some receptors in normal cells, but it's overexpressed in neuroendocrine tumors. We can discuss that later on in more detail. So what radioisotopes are used in Prrt? The two major isotopes are used are yttrium-90 and lutetium dotatate. So these are the two major ones that are used currently. In the past, there were other agents used, for example, indium octretide, high energy indium octretide, which some patients have had in the past. So going on to patient selection. So which patients would benefit from Prrt? There's many options for treatment in patients with metastatic neuroendocrine tumor. So we have to select the right treatment for the right patient. So this is not how the decision is made in the multidisciplinary team meeting. It's not Dr. Tumfanakis giving all the orders. It's done. It's done through a multidisciplinary team approach. And these are the people that are available in the multidisciplinary team. So we have the gastroenterologist or endocrinologist who look after the patients on the mainstream, medical oncology who can provide chemotherapy options. Then there's the histopathologist, radiologist, and nuclear medicine physicians who show the imaging as well as the histology of the patient, so we can make the correct decision. Then there's the CNS, which is the nurse specialist, and they have a vital role in knowing how fit the patient is for the treatment and to coordinate the appropriate treatment for the patient. There's also a surgeon in the room. So in patients who've got a potential surgical option, so surgical curative option, that should be the first line treatment and not Prrt. So patient selection, these are the main selection criteria. They need to have a histologically proven neuroendocrine tumor. They must be somatostatin receptor positive, so they should have a scan showing that they're somatostatin receptor positive. They should have no surgical cure possible, because that should be the treatment of choice if there is a surgical cure available for this patient. And they should have progressive disease or uncontrollable symptoms. And I'll discuss that in a little bit more detail later on. So these are the main criteria for patient selection: histological grading, tumor primary, somatostatin receptor imaging, cross-sectional imaging, blood tests, and functional status of the patient. So I'll try to keep it as non-technical as possible, but if anyone wants more details, please ask questions at the end. So histological grading, we've got something called the Chi-67 index, which is the proliferative index of the tumors. So there's 3 grades: grade 1, grade 2, and grade 3. So those patients with well-differentiated tumors have high level of somatostatin receptors, and they are likely to respond to PRRT. While those who are more aggressive tumors, the G3 tumors, tend not to have a high level of somatostatin receptor uptake, and they don't tend to respond. So we use this as a basis for to decide what sort of first-line treatments to give. In patients with G3 tumors, however, if they do have good uptake on the somatostatin receptor scan, they can have this treatment at a later date. So the more aggressive tumors, like I've said, have less somatostatin receptors. So the tumor primary, this is the ENETS, which is the European Neuroendocrine Tumor Society guidance, which, if you look at here, all patients with G1 or G2 tumors are eligible for PRRT as long as that they've got enough uptake on their scan. However, here it's not the same for all patient groups. For pancreatics and other foregut tumors, chemotherapy is usually the first-line treatment, because that's also an effective treatment. And if there's progressive disease later, then PRRT can be used. Whilst in patients with mid-gut tumors, so gastrointestinal mid-gut or hindgut tumors, those tumors tend not to respond well to chemotherapy, and in those that progress, PRRT is usually the first line of treatment. So somatostatin receptor imaging, this is the key, because if you don't have enough uptake, you're unlikely to respond to treatment. And we use the theranostics, theranostics principle. Theranostics is a combination of diagnostics and therapy. So you should have sufficient uptake on molecular imaging, receptor imaging, so somatostatin receptor imaging, using our new PET tracer, gallium-68, or if that's not available, indium octretide. And then if you've got sufficient uptake, then you can use molecular radiotherapy with yttrium or lutetium labeled peptides. So you use the same peptide for both the imaging and the therapy, so you know that you're going to get the same uptake in the, both the imaging and therapy. So you can predict that someone's going to have good uptake on the scan, and thus good response. So this is key. If you don't have enough uptake, there's no point in doing this treatment, because it's unlikely to work. So what sort of uptake are we looking for? So those that are suitable, if you've got uptake greater than background liver, and you should have uptake in all tumors. Like I've said, higher tumor uptake correlates with better response. So this is an example of, this is an example of a patient. This is the gallium-68 dotatate PET scan. So this is a PET scan labeled with the somatostatin receptor. And like your question, there's quite a few organs that have normal uptake. So the salivary glands, the pituitary, excretion in the kidneys, and the adrenal glands have normal uptake. But all these hot spots, or the hyperactive spots in the liver, are abnormal, and they represent tumor cells. So this patient has sufficient uptake in all the tumor sites, and this patient is suitable for PRRT. So not suitable are patients who have uptake less than that in the liver, no uptake in all the tumors, so you've only got 1 or 2 sites that have uptake, whilst the rest don't have uptake. And if it's the rest that are getting bigger, no point in treating the ones with a treatment that's not going to target those lesions that are getting bigger. So lower uptake correlates with poor response rates. So if you look at this patient with a thymic neuroendocrine tumor, so all of these low levels of uptake are metastasis, but the uptake is very low, much less than that of the liver, and this patient, if treated, won't respond. There are clinical trials that showed that with this level of uptake, the response rate is very low. So this patient won't get treated with PRRT at our institute or anywhere else. No uptake in all lesions. So this patient also won't be suitable for PRRT. So if you look, this is the gallium dotatate scan, and this is an FDG PET scan, which works on the principle of hypermetabolism. So the tumors that are slightly more aggressive have more metabolic need, and you can see that these two spots in the liver are not seen, and the pancreatic tumors also only got low-grade uptake on the gallium dotatate scan. So this patient also not suitable. So going on to cross-sectional imaging. So it's not just the gallium dotatate PET scan that is useful. Cross-sectional imaging is also vital, because this is the imaging that we do sequentially. So we look to see when patient has evidence of disease progression, because as you know, some of these tumors can be slow growing. So if you've got stable disease over a long period of time, there may not be any need to escalate treatment at that point. Is there a surgical option available? So we need this cross-sectional imaging to look at the relationship of the tumor to vessels, and with the surgeon there to see if it's technically feasible. The tumor dynamics, the rate of progression, so if progression is very quick, then chemotherapy may be a better option than PRRT, because it takes a little while for PRRT to work, to be effective. And then we can also look at extent of disease. So blood tests. So you must maybe wondering why you have so many blood tests when you have PRRT. And the reason for that, because there are some contraindications to PRRT, because you can get some side effects from the treatment. So those with reduced kidney function, there's a small chance of you developing kidney failure. I'll go through that in more detail later on. But those with lower kidney function are going to have a higher chance of that happening. Reduced blood counts. So reduced blood counts can be dangerous. So we don't treat anyone who's got too low platelets or too low white cell count, as there's the increased risk of them having bleeding or having infection. And we wait. If post-treatment the counts go down, we wait until the counts come up to a reasonable level before treating. Those with severe problems with the liver, them as well, you can result in liver failure from this treatment. So we wouldn't treat if you have severe liver dysfunction. That's not the norm. Even in patients with a lot of liver disease, you still tend to have preserved liver function. So that's not the norm. That's not usually a contraindication. So lastly, the functional status of the patient. So, because like I said, it takes a little while to work, usually 1 to 2 treatments, which is spaced 6 to 8 weeks apart. Should have a reasonable life expectancy. Should have a reasonable performance status as well. They should be self-caring, because once you have radioactivity, there's some sort of radiation protection precautions, which again I'll go through a bit later. So you should be self-caring, and baseline weight loss and previous treatments are just parameters that can look at whether you're going to respond or not. So who should we treat? Technically, this motto is true. So if you can see it on the somatostatin receptor imaging, you can potentially treat it, because all neuroendocrine tumors can potentially be treated with PRRT, provided that they have sufficient uptake on the somatostatin receptor scan. However, we need to be a bit judicious about who to treat. As I've said before, neuroendocrine tumors can be slow growing, and so the timing of treatment can be debatable. The established indications about when to treat are those patients that have got progressive disease. So if the CT scan shows that the tumors are growing, this is the time to treat, because the disease is not stable, and we need to do something to either make it respond or go back to a stable state, which may last for many years. If patients are symptomatic despite cold analogs or other forms of treatment, that's another indication for treatment. For treatment failure with the somatostatin analogs, so we'll escalate to PRRT. Another potential indication is prior to surgery, so sort of the neoadjuvant, which means sort of trying to downstage patients so that they can become surgically curative. So this is not the majority of patients, but a small minority of patients, if they've got a small volume of disease, it's possible that you can downstage them such that they can be treated surgically and cured. When not to treat, if things are moving very quickly, rapidly progressive, like I said, it can take 3 or 4, even more months to see effectiveness from this treatment. So if things are progressing quickly, we need something to abate that, and maybe PRT a little bit later. Poor performance status, again, you can make things worse and you can make patients unwell. And as a last resort, we should be looking to treat patients earlier so that they can benefit from the treatment. If you treat too late, the likelihood is that the benefit may not be as good. So outcome and toxicity data. So there has been a criticism of the studies performed using PRT, saying that the studies that have been done not or have all the same tumor types, don't have patients with progressive disease at the entry point, the number of treatments given, and the amount of activity given varies between different studies, and the reporting criteria is different as well, using different CT reporting criteria, not giving symptomatic response, and there's currently no randomized controlled trials that have been reported, which is the gold standard for all sort of research. However, despite all of this, there's no doubt that PRT is an effective treatment in somatostatin receptor expressing neuroendocrine tumors, with several clinical trials showing improvement in quality of life as well as prolonging life. And this is an interesting paper by Dr. Kwekeboom and colleagues in Rotterdam. If you look at the white bars, are those in patients who, when PRT wasn't available, and the black bars when PRT was available. And you can see the overall survival from diagnosis is much better in patients when PRT was available across the spectrum of different types of neuroendocrine tumors. So there's no doubt that there is effectiveness. It's just not the right trials to that have been robust about it. There are a few trials now that are coming about, which will report in about 3 or 4 years' time. So just to show you some examples of response to treatment. So this is a patient with neuroendocrine tumor liver metastases. So you can see this is after the first treatment. After the third treatment, the majority of the liver metastases have reduced or resolved. This liver metastasis has completely gone, while this has reduced significantly. This is the SPECT-CT, the 3D fused image. Another example of a patient, this is after 4 cycles of treatment. After the first cycle, you can see multiple, so all of these hotspots in the bones are bone mets, large liver tumor here. You can see the bone mets progressively reduce. The liver tumors as well progressively get smaller. And if you look at the 3D SPECT-CT image, this one is gone out of focus, but if you look at the first, second, and fourth, you can clearly see that there's been an excellent response. In fact, one of the radiologists thought that the patient had had a resection. It wasn't a resection, it was PRT that caused this response. So this is a very busy slide, but I just want to make one comment on this. So time to progression using Y90 dotatate. So again, the studies were quite heterogeneous, but between 12 and 29 months is sort of the average time to progression after having treatment with yttrium-90 dotatate. Bit better.
What do you mean by progression?
Tumor starting to get bigger again. So
29 months from the time of last treatment.
that's right. So yeah, so with the lutetium, it's a little bit better than that. Between just over 3 years. This is the average. So it's not. This is the mean time to progression. So some may have much less than this, and some may have much more than this. But on average, it's approximately 3 to 3.5 years for lutetium, and a little bit less for yttrium. But the studies using yttrium were not as well designed. So this is a pilot study at the Royal Free Hospital where we looked at the quality of life of patients. After just one cycle of treatment, we can see all patients' symptoms, including endocrine symptoms, gastrointestinal symptoms, treatment-related, disease-related worries, social functioning, and overall score had reduced after this treatment. Only treatment-related symptoms had increased because the patient was treatment naive to start with. So obviously that's going to increase because they didn't have any treatment before that. So it looked like the quality of life also improved significantly after PRT, after just one cycle. You won't see you probably won't see a change in the tumor burden at this time, but you can already see that patients are starting to feel better. What are the main toxicities of this treatment? So renal toxicity is one. So you can get, with yttrium-90 dotatate, there's a range of between 1 and 9% of renal failure being reported. So predictors of severe toxicity include advancing age or low baseline kidney function. At our institute, the toxicity is on the lower range, between 1 and 2%, but there is no doubt that there is toxicity to the kidney with yttrium as well as lutetium. With lutetium, it's about 0.5% of patients develop a permanent renal failure following 4 cycles of lutetium. So it's less with lutetium because yttrium has a more energetic particle, lutetium slightly less energetic particle that affects the kidneys a little bit less. The other main toxicity is bone marrow toxicity, which means blood counts. With both lutetium and yttrium peptide, there is reduction in blood counts, lutetium in approximately 9% of patients, and yttrium in approximately 12% of patients. Almost all of these patients are reversible, so you'll get significant toxicity, but if you give it some time, it reverts to normal after a small period of time. Secondary malignancy, that's sort of blood malignancies, sort of example leukemia or myelodysplastic syndrome, that can occur. It's extremely rare, only a few cases been reported. It's those patients that have had a lot of other treatments, a lot of other chemotherapies, previous radiotherapy, and probably less than 0.5% in total of patients that will develop this. So lastly, just briefly, I'm going to talk about the practicalities in PRRT. So stopping the somatostatin analog, radiation protection advice, and travel advice. So stopping the long-acting analogs, many patients are on long-acting analogs to control their symptoms and control their disease. For example, lanreotide autogel or sandostatin LAR. The cold analogs, however, can bind to the somatostatin receptors and can reduce uptake by PRRT, and thus potentially reducing the effectiveness of the treatment. And that's the reason that we ask patients to be off that for 4 to 6 weeks prior to having this, so we can maximize the uptake within the somatostatin receptors and therefore maximize the response, potentially maximize the response. This is the radiation protection advice that patients at our institute live with. So this is for lutetium, and basically it's sort of do's and don'ts for 1 week and then 2 weeks. So for example, refrain from close contact with young children and pregnant ladies for a week, and very close contact, so less than 30 centimeters from other adults. And 2 weeks there's some other do's and don'ts. Again, very close contact from young children and pregnant women. Avoid sharing a bed with another person. And other practical advice, good hand hygiene, because some of the radioactivity that's not taken up by your tumors is excreted in your urine. So if you have good hygiene, you're not going to contaminate anything. So this is the last slide. So this is a slide of the restriction period that was after PRRT, before you can fly. So we have some patients that from the Channel Islands, for instance. So we had to devise this to see when patients can fly, and without, you're still likely going to set up the detectors at the airports, but to be safe to other passengers, if you're doing a flight that's less than 2 hours, you can fly the next day, so on the day of the discharge, which is the day after treatment, without any further time. And as you go for longer flights, there's more amount of time that you need to wait before being able to fly safely. Safety meaning radiation to other people that are on board of the plane with you. So thank you very much for your attention. I'd like to invite some questions.